Hello all, welcome back. Today we'll be discussing the rest of the questions from the MRCP website sample questions with detailed explanations for the answers. Question 66. A 72-year-old man presented with a 2-day history of pain and swelling of right knee. Analysis of synovial fluid from the right knee confirmed the presence of calcium pyrophosphate crystals. What is the microscopic appearance of these crystals? So it is pain and swelling of right knee with calcium pyrophosphate crystals. Where do you see this? You see this in pseudogout. And you have to know the appearance of the crystals in gout as well as pseudogout. In pseudogout, it is a rhomboid shape with positive birefringence, and in gout, it is needle shape with negative birefringence. You can remember it like N for N, and gout is negative. Okay, gout is negative shape with a needle shape with negative birefringence that you see in gout, and this one you see in pseudogout, that is rhomboid shape with positive birefringence. Next question. A 70-year-old man presented with 2-week history of persistent fever. 6 weeks previously had undergone colonoscopy and biopsy for a suspected carcinoma of colon and was awaiting surgery. Had a history of moderate mitral regurgitation caused by mitral valve prolapse. Echo showing a vegetation on the anterior leaflet of mitral valve. So, fever and now having mitral regurgitation and vegetation. So it is a course of a diagnosis of infective endocarditis. We are being asked what is the most likely causative organism. So for infective endocarditis, the overall most common cause is Staph aureus. Okay, overall most common cause is Staph aureus. So if there is no other association, or even if it is in a drug abuse, skin infection associated, all that is Staph aureus. With prosthetic valve, it is epidermidis. Okay. With tooth infection and all, it is viridins. Viridins, Streptococcus viridins. With your colon cancer, association with colon cancer is Streptococcus gallolyticus or bovis. Okay, this is another favorite question. They also ask like if you have infective endocarditis and the causative organism is found to be bovis, what is the next line of investigation you have to do? Then you have to do a colonoscopy to rule out carcinoma colon, because when it is bovis, there is usually association with colon cancer. So you have to do a colonoscopy to rule out colon cancer. They can ask in either way. Okay, it is bovis. Overall most common cause is aureus, tooth extraction, viridins, prosthetic valve, epidermidis. Next question. A 75-year-old woman presented with 2-month history of generalized malaise and headache that had disturbed her sleep. For the past 24 hours, she had been unable to see with her right eye. She had a history of glaucoma and was using regular timolol eye drops. On examination of the fundus, there was a swollen, pale right optic disc and a normal left optic disc. What is the most likely diagnosis? So it is she's having malaise headache, and now she's unable to see with her right eye. She had a history of glaucoma and was using timolol. Now, on examination of fundus, there is pale optic disc. Okay, what is and a normal left optic disc? What is the um uh, cause of her sudden loss of vision? Options are central retinal vein occlusion, closed angle glaucoma, Schinn cell arteritis, optic neuritis, raised intracranial pressure. So here we can see there is a pale optic disc. When there is a pale optic disc, there is some kind of ischemia. Okay. In central retinal vein occlusion, it is sudden painless loss of vision, but the optic disc will not be pale. In central retinal arterial occlusion also, the pale optic disc will be pale and it will be painless loss of vision. But here there is headache, severe headache of a 2-month history. So it is not an acute, even like a CRVO or a CRAO. It is a prolonged event, and superimposed to that, something has happened in the acute setting. For the past 24 hours, she's having this sudden loss of vision. Okay, she had a history of glaucoma also. Okay, so this could be, her headache could be giant cell arteritis. Okay, and in giant cell arteritis, you have something called anterior ischemic optic neuropathy. Okay, anterior ischemic optic neuropathy. Optic neuropathy. Okay, so it is giant cell arteritis. Giant cell arteritis. Okay, next question. A 66-year-old man who was undergoing maintenance hemodialysis through a subcutaneous tunnel catheter presented with fever, chills, and rigors during hemodialysis. On examination, his temperature was 38.6, pulse was 105, BP was 100/60. Examination of his respiratory cardiovascular system was normal. What is the most likely cause of his infection? So, infection associated with tunneled catheter. The usual organism is epidermidis. Okay, if you know kind of question, it is epidermidis associated with your tunnel catheter, infection associated with tunnel catheter. Most common organism is epidermidis. Next question. A 72-year-old woman with rheumatoid arthritis presented dysuria, rigors, and high fevers of 2 days duration. Her regular medication comprised methotrexate, prednisolone, and paracetamol. On examination, her temperature was 39 and she was tender in both flanks. Her BMI was 34. Urine culture showed coliform sensitive to Ziplocs. Which condition is most likely to be precipitated by the use of Ziplocs? So in some questions like this, the all of the history and all is insignificant when it comes to answering your question. So it is asking what is the commonest side effect of using ciprofloxacin. We'll look at the options. Gastric ulceration, glucose intolerance, hepatitis, pneumonitis, tendinopathy. So it is tendinopathy. Okay. Ciprofloxacin can cause tendinopathy. It is also contraindicated in pregnancy for the same reason. So it causes tendinopathy. Next question. 35-year-old woman presented with 6-month history of episodes of sweating, joint pain, and headaches. On examination, her BP was 160/90. Plasma glucose, fasting plasma glucose is 8.1. A clinical diagnosis of acromegaly was suspected. What additional investigation is most likely to confirm the diagnosis? So they are asking confirmatory test for acromegaly, not the initial line of investigation. Initial line of investigation, you do a serum IGF-1, but confirmatory test is your growth hormone suppression test. Growth hormone suppression test. But initial investigation is your insulin-like growth factor 1. Okay, but confirmatory test is growth hormone suppression test. Next question. A 25-year-old man presented a 3-month history of hearing two people commenting on his actions. For the past 2 years, he had become increasingly withdrawn and had neglected his self-care. He had graduated from university at 21 years of age but had never been employed and had few friends. He had taken an overdose of paracetamol 2 months previously. He had smoked cannabis regularly for 5 years. He drank 60 units of alcohol per week. On examination, he made poor eye contact and his speech was disjointed. What is the most likely diagnosis? So he's hearing people commenting on his action. Okay, and he has also withdrawn himself and his self-care. But previously, he had been graduating from university and all. We look at the options: alcohol-related hallucinations, hallucinosis, borderline personality disorder, cannabis-induced psychosis, paranoid schizophrenia, psychotic depression. So when you are hearing two people commenting on actions and all, it is schizophrenia. Again, schizophrenia has positive symptoms and negative symptoms. Positive symptoms is your delusion. Delusion is a false, strong belief despite evidence to the contrary. That means if they believe that it is night and they know it is, they're being told it is day and they see daylight, they refuse to believe in that. That is delusion. Hallucination means it can occur in different forms like auditory hallucination, visual hallucination, tactile hallucination. That is, they are having they're hearing something. That is auditory hallucination without the presence of the stimulus. Okay, that is hallucination. Disorganized speech can be there, and also uh, thought broadcast. Okay, their thought being taken away. They can think that they are being asked to do something. Okay, all of that, those are your positive symptoms. What are your negative symptoms? A flattened effect. Your mood is low. You don't you have a social withdrawal, a lack of initiative, reduced speech. That is your negative symptoms. So schizophrenia can have your positive symptoms and negative symptoms. Okay. Okay. So what is the difference between illusion and delusion? Illusion means there is a stimulus. Okay. But you think, like if you um, see a stick, you think it as a snake. So there is a stimulus, but you have an altered perception of that stimulus. That is your illusion. Delusion is you believe in a false belief despite evidence to the contrary. Hallucination is you don't have the stimulus, but you feel it, like tactile hallucination is like ants crawling over your body when there are no ants or no stimulus as such. Okay. Next question. A 56-year-old man presented with double vision. On examination, he had bilateral partial ptosis, diplopia, and truncal muscle weakness. X-ray showing widened mediastinum. So, okay, so there is widened mediastinum. There is ptosis, diplopia, and muscle weakness. Truncal muscle weakness. Look at the options and also double vision. Dermatomyositis. Dermatomyositis usually have your heliotrope rash. You can have proximal muscle weakness. Okay. Lambert-Eaton myasthenic syndrome. What is Lambert-Eaton myasthenic syndrome? It is a presynaptic calcium channel. Um, it affects the presynaptic calcium channel, and it is a paraneoplastic like manifestation. Okay. And what is malignant meningitis? That has meningitis-like picture. Here it is not the case. Mononeuritis multiplex. That means different site, different nerves are involved. Like for example, the patient can have a common peroneal nerve palsy. The patient can have a carpal tunnel syndrome. So different level, different nerves are affected. That is mononeuritis multiplex. Myasthenia gravis is a postsynaptic acetylcholine uh, um, receptor problem, and again they can have a ptosis and all. Okay, so we'll look at the options and then think of whether there is any association. So your myasthenia can have ptosis. Okay, myasthenia can have a fatigability of the muscles. Okay, and also the main difference between Lambert-Eaton and myasthenia is that Lambert-Eaton has an increment response. That is, there is weakness initially, but once you put that muscle to use, the muscle can show an increment response. But myasthenia shows a weaken in response when it is being put to action continuously. So Lambert-Eaton has an increment response, myasthenia has a fatigability. So here there is ptosis, and due to that ptosis and diplopia, the ptosis and weakness, you can have diplopia and you have muscle weakness. So that goes with myasthenia gravis. So what could be this widened mediastinum? That could be a thymoma, because myasthenia has an association with thymoma, and thymectomy is one of the management of myasthenia gravis. So it is myasthenia gravis. We'll look at the difference between myasthenia and Lambert-Eaton because they are uh, similar in some manner and different in some manner. So myasthenia is antibody against acetylcholine receptor antibody, and it is a postsynaptic problem. Lambert-Eaton is antibody against voltage-gated calcium channel, and it is a presynaptic problem. So it is presynaptic. Myasthenia is postsynaptic. Myasthenia is associated with thymic tumor, and Lambertitan is a paraneoplastic associated with small cell lung cancer. Myasthenia weakness prolongs on prolonged exercise. Lambertitan weakness improves on prolonged exercise. That is your increment response. Even when you're doing a nerve conduction study, you can elicit that increment response. Normal deep tendon reflex in myasthenia, absent deep tendon reflex in Lambert-Eaton. Autonomic dysfunction is absent in myasthenia. They can be present in Lambert-Eaton. On repeated nerve stimulation, there is a decremental response. On repeated nerve stimulation, there is incremental response in Lambert-Eaton syndrome. It's a paraneoplastic syndrome affecting the presynaptic voltage-gated calcium channel. Both of myasthenia and Lambert-Eaton are manifesting as muscle weakness. In myasthenia, you also have ptosis, mainly affecting the ocular muscles. Lambert-Eaton is affecting the other muscles, trunk muscles. Next question: a 75-year-old woman with hypertension had been treated with benroflumethiazide for the past 5 years. So I said thiazide diuretic. On examination, BP was 125 over 78. Sodium is 140, potassium is 3.2, a bit low. Creatinine is 67. What is the most likely mechanism of hypokalemia? We look at the options. So it's a thiazide diuretic causing hypokalemia. What is the mechanism of hypokalemia is they are asking. Options are increased loss in distal tubule, increased potassium secretion in proximal tubule, opening of potassium channel in principal cells, reduced aldosterone secretion, reduced potassium reabsorption in loop of Henle. So I'll give you a picture to try and remember the site of action of different diuretics, because once you know the site of action, the mechanism becomes easier. So you have your your proximal convoluted tubule. Okay, you have your proximal convoluted tubule. You have your descending limb of loop of Henle, ascending limb of loop of Henle, and your distal convoluted tubule finally going into the collecting duct. Okay, so this is your collecting duct. To remember that, you can remember Colt P. Colt P. Colt P. Okay, the diuretics are increasing urine, so you remember it like cold P. What is C? Carbonic anhydrase acting on PCT, carbonic anhydrase inhibitor, like your acetazolamide. O comes for your osmotic diuretic, which is acting on the loop of Henle. L for loop diuretic acting on the ascending limb of loop of Henle. Then comes your T, that is thiazide diuretic acting on the distal convoluted tubule. Then you have your potassium sparing, which is also acting on the distal part of the distal convoluted tubule or your collecting duct. So it is your cold P, C for carbonic anhydrase inhibitors acting on the PCT, O for osmotic diuretic acting on loop of Henle, L for loop diuretic acting on ascending limb of loop of Henle, T for thiazide diuretic acting on DCT, P again acting on the distal part of DCT. That is potassium sparing diuretic like your spironolactone. Loop diuretic example is your furosemide. Okay. So here, increased loss in distal tubule. So it is acting on the distal tubule. Increased potassium secretion in proximal tubule. That is wrong because it is not acting on the proximal tubule. Opening of potassium channel in principal cells. Reduced aldosterone secretion. Reduced potassium reabsorption in loop of Henle. So the answer is increased loss in distal tubule. That is where it is acting. Next question is a 25-year-old injecting drug user presented with an injection site abscess. On examination, his temperature was 38.5 and there was a pansystolic murmur. What organism is most likely to be cultured from both abscess and the blood? So I told you it's a case of infective endocarditis. Okay, pansystolic murmur with the skin abscess. So I told you any other cause other than your colon cancer, your tooth extraction, or your prosthetic valve, any other cause, the most common cause of infective endocarditis is Staph aureus. So here also it is Staph aureus because Staph aureus can cause your skin infection, especially in a drug user. And It can cause an infective endocarditis. So it is Staphylococcus aureus. Or they can even ask you, like, in the culture, the organism is coming as a, a group of cocci in clusters. So that is the characteristic appearance of Staph aureus. There was a question in this MRCP August which they asked. They described an infection caused by the staph. I don't remember if it was infective endocarditis or a skin infection. And then they told in the culture it is showing a gram-positive cocci in clusters. So gram-positive cocci in clusters is Staph aureus. Gram-positive cocci in pairs and chains is your um, streptococcus. Okay. Next question: a 63-year-old woman with a history of CREST syndrome developed progressive breathlessness. On auscultation, she had bilateral basal crackles. Chest X-ray showed lower zone shadowing. What is the most likely diagnosis? So they are asking CREST syndrome and what is the association, pulmonary association of CREST syndrome. So it is interstitial lung disease. Interstitial lung disease. Okay, CREST syndrome can be associated with interstitial lung disease. CREST syndrome, C stands for calcinosis, R for Raynaud's, E for esophageal dysmotility, which is actually esophageal reflux, S for sclerodactyly, which is thickening of the skin over the fingers, and T for telangiectasia. That is a classical of the limited cutaneous systemic sclerosis, and the antibody associated is anti-centromere. These are the usual questions coming from that CREST syndrome part. Next question: a 30-year-old doctor presented following a needle stick injury sustained while treating a patient with recently diagnosed HIV. The patient was hepatitis C negative and had been against hepatitis B virus and was not taking any antiretroviral treatment. What is the most appropriate post-exposure prophylaxis? So the recommendation for post-exposure prophylaxis is 3-drug antiretroviral treatment for 1 month. 3-drug, 1 month. Okay. Next question: a 21-year-old woman who was undergoing chemotherapy for non-Hodgkin lymphoma presented 2 days after being in contact with her nephew for 2 hours on the day that he developed a chickenpox rash. Okay, so an immunosuppressed patient receiving chemotherapy for NHL with a varicella contact. The varicella serology is negative. What is the most appropriate management? Look at the option. Advise her to seek treatment if she develops a chickenpox rash. Interrupt chemotherapy for 2 weeks. Oral acyclovir 800 mg 5 times daily for 1 week. Varicella immunization. Varicella zoster immunoglobulin. So in this case, the patient is severely immunocompromised. You have to give varicella immunoglobulin. Okay, because she was not protected against varicella and she is high contact with a person having varicella. Next question. A 21-year-old woman presented with watery diarrhea and cramping abdominal pain 5 days after arriving in Mexico. On examination, her temperature was 37.8 and there was mild abdominal tenderness. There was some mucus in the stools but no blood. What is the most likely pathogen? So she has traveled to some area and she's having diarrhea with no blood. Okay, and there is abdominal tenderness, there is mucus in stool but no blood. So traveler's diarrhea, right? That is enterotoxigenic E. coli. Diarrhea can cause again in endemic areas like travel to India. They can cause, but it's a prolonged history they would give. Okay, so it is enterotoxigenic E. coli, which is called as traveler's diarrhea. Next question: a 36-year-old HIV positive man presented with 1 week history of generalized pruritus. He had had unprotected anal sex 2 months previously while on holiday in Spain. He had previously been vaccinated against hepatitis B virus with an adequate antibody response. On examination, his temperature was 37.8 and it was jaundiced. Otherwise, examination was normal. Bilirubin is 99, AST is 754, ALP is 173, CD4 count is 550. Anti-hepatitis A IgM antibody is negative. So it is HIV positive man with 1 week history of generalized pruritus, and he had unprotected anal sex. So it does some sexually transmitted virus, but he was previously vaccinated hepatitis against hepatitis B with adequate response, and now he's having anti-hepatitis A is also negative, and the transaminases AST is very high with high bilirubin. So it is like a fulminant liver failure. So that can be sexually transmitted, which can cause an acute hepatitis. So here, among the options, acute hepatitis C, it can be acute hepatitis D, that can only get as a super infection along with hepatitis B. It cannot affect alone. CMV infection, no, not likely, especially because the CD4 count is not that low. Syphilis, no. Toxoplasmosis, no. It is acute hepatitis C. So that's all. We'll come with the next round of questions in the next session. Thank you for listening. Um, Thank you.